Good day, my dear postgraduate students. I have now taken a topic from Recent Advances 19. It is a dictum that any topic in recent advance can be asked as a question, and the student shall and will know it. Always I used to say that the authors of a particular topic have rendered a great deal of service in analyzing that one in great depth. So I shall try to present what they had done. Think of the subheadings. The subheadings will take you to the answer. And these are the subheadings. Even if you are not able to recollect the entire text, if you do think of the subheadings, at least part of it will be able to answer. It is a congenital disorder. Some people say it can be partly sporadic, partly congenital. Found in about 1 to 1.63 per 10,000 live births. Owing to surgical intervention at an appropriate time, the mortality has now come down to 3%. Otherwise, it was severely fatal. It consists of the total absence of the ganglion cells in the Meissner's or the Auerbach's plexus. And the symptoms include constipation, intestinal obstruction. A lot of interprofessional care is needed, as will be explained. This is Hirschsprung. He is from Copenhagen, and this is his life history. He was a physician who had diagnosed many rare diseases, including rectal achalasia, which is the Hirschsprung's disease, esophageal atresia, pyloric diseases, intussusception were all found by him. And teaching in small groups was his field of interest. I hope you people know this particular story. It is about two women claiming the rights for a child. And the case came up to King Solomon, who was very judicious in giving his judgments. And what he did was, he gave a judgment of both appear genuine. So let us divide the child into two and give him each one a half. Immediately, the original mother said, let the child be with the other woman. And it was judged that that lady was the mother and the judgment given. This painting is incidentally from Wikipedia Commons and by the Electric Company of Vatican City. So this is what I had said. About 65% of the cases are diagnosed within a month and 95% within the first year. Rarely it can occur in adults because of a sporadic nature. The other abnormalities include those in the CNS, GAT, and the cardiac systems. Male-female ratio is 4:1. Thanks to Priyanka Singh. Always I used to adore her for the wonderful illustrations that she brings up. What can be the clinical presentation of a Hirschsprung's case? Okay, the bloating of the abdomen, and there is an indigestion of fatty foods. There is a vomitus that is constantly being produced, admixed with bile. Failure to pass meconium. But there is no abnormality in the feeding. bilious vomiting is over here. And I hope that there is an end to the vomiting and you place the things right in the sense that there is something abnormal in this case to be investigated within 24 hours of a beautiful illustration. I think this summarizes everything. Coming to the classification. So there is the anus and then the rectum, anorectal junction, and the sigmoid colon. In one, the disease can be limited to A, the sigmoid colon, whereas in the others, this is a conventional form which I had mentioned. In the others, you find that there can be a longer aganglionic segment, including the descending colon. And finally, you have got A, B, and C, total colonic aganglionosis, and sometimes it can extend into the small intestine also. So this is a fundamental classification of Hirschsprung's disease. I would like you people to kindly remember and draw this diagram. So this is one. I find that there is a contracted area and then there is a dilated or a distended area as shown in this contrast X-ray. You find that there is a spasm and then there is a coning. I find this region is conical and then there is a distended segment. So there is no ganglia in this region. This is the transition zone and then this is the normal zone. What are the modes of transmission? I would like you people to kindly read through this particular slide slowly. It is complex and has got multigenetic inheritance, weak penetrance, and sex dependent. That is why you find that both males and females are affected. Read proto-oncogene is the main gene that is affected. Read means rearrange during transfection. That is the proto-oncogene. More than 100 mutations, something like a thalassemia, is there. Nonsense, missense, deletions, and insertions. These are all various abnormalities that could occur in this particular case. The other genes are the ligands for R.A.T receptors, namely GDNF, glial-derived neurotrophic receptor, endothelin 3, endothelin B, SOX10, and FOX2B. These are the things quite easy for you youngsters to memorize. I would like you people to kindly do it. This will form the crux of today's class. So this again is a photograph of the original lesion. You find that there is a transition zone, then a distended zone. This obviously is a ganglionic segment over here. Earlier I had told you a case of the judgment of Solomon. And if you observe carefully, the child would have been held in an upside down position. And that is because there was a gas of air that could be demonstrated. And so this is called the judgment of Solomon position, which is the diagnosis for an imperforate anus. So the gas goes up and then it is being diagnosed as imperforate anus. Whereas in a case of a Hirschsprung's, you find that there will be multiple locules of air being locked in the distended segments. The radiological evidence of both. This is a normal section of the colon. Acetylcholinesterase positive. You find that both in the submucosal region and the muscularis mucosa, there will be the acetylcholinesterase. And once it is present, it leads to normal peristalsis. Whereas when it is going to be absent, there can be a constipation, failure to pass the stools, a delayed meconium, megacolon, enterocolitis, These I shall be explaining later on. And if left, there can be an intestinal perforation. Other genetic diseases, strangely, I do not know how, that are linked with it have been Down syndrome, a Waardenburg syndrome. A picture of it is over here. Familial deafness, a pale skin, and pale eyes and hair. The patient also has got a broad nose. Another one is on-time skulls, to die as usually. I do not know what this actually implies, but then these have been mentioned as connected with Hirschsprungs. It was originally found out by the anatomist Friedrich Rusch and later on by Harold Hirschsprung, after whom it has been named. Now, look at the neural components over here. These are the various things. These are the mucous folds. There is a mucous plexus, submucosal plexus. All these lead to the nervous system as such. Then there is a myotic plexus, which is very important, wherein I can see some ganglion cells also, or the glial cells. And there will be the extrinsic nerves. So the ganglion cells are more important in the peristalsis. And this is a histological picture of the same. I am finding large cells with large vesicular eccentric nucleus, prominent nucleoli, and something like a sand and pepper type of chromatin. So this is a schematic picture of the same. You find that there is a mucosa, submucosal plexus of Meissner, and then there is a circular muscle. There will be the Auerbach's plexus, which is more important. It is this region exactly between the circular and the longitudinal muscles that we should search for the ganglion cells. Thanks to Journal of Medicine and Life. This again is the Auerbach's plexus. I would like you people to kindly appreciate the wavy bundles of nerves within which there are these eyes that I could see, namely the ganglion cells. So also over here, in between the circular and the longitudinal muscles, exactly the region where we should search for. Ganglion cells of the Auerbach's plexus have got the characters that I have mentioned: eccentric nucleus, abundant eosinophilic cytoplasm. These ganglia are about 1 to 19 in number. Sometimes we call it as hypoganglionic rather than aganglionic when the number is markedly reduced. In the submucosal plexus, ganglion cells are closer to the inner circular muscles. The cells there are much smaller. And in premature babies, ganglion cells have got no nucleoli or a stippled nuclei. In Hirschsprung's disease, on the other hand, you find that there is a transition zone, and this might be irregular. That is why 2 biopsies will be needed so that we can diagnose a ganglionic and a hypoganglionic, or a aganglionic and a hypoganglionic segments. This is again the same picture. Minimal 2 biopsies will be needed. There are different types of these biopsies. One is a suction rectal biopsy. The problem here is very little tissue is there. And sometimes the surgeon will be pressurizing us with a frozen section, and these ganglion cells are very difficult to decipher. Karnowski and Roots were the person who did the staining of the aganglionic segments over here. And in this, I'm able to see acetylcholinesterase positive areas that is staining the nerve segment. Ganglion cells are absent in Hirschsprung's disease. And what is the actual etiology of this particular disease? Why should it happen at the fag end of the gastrointestinal tract? So this is the neural plate. And what I am seeing is something like this. There is a neural plate over here. The notochord is lower down, and you find that there is a non-neural ectoderm and a neural plate border is over here. And there is a bend and of the neural plate, a neural crest is being formed. And also you find that there is a demyelinated neural segment, and also there is a neural tube that is formed. From this neural tube, you find that there will be the cells that migrate down and go down to the distal end of the gastrointestinal tract. Now, when there is going to be a defect in this migration, you find that the distal end will not be having the ganglion cells. So you have the so-called Hirschsprung's disease. Look at this over here. There is a disruption in the migration. It is an important slide for you people. And there is a failure in the differentiation of the neural crest cells. This is regulated by the R.A.T.S gene and its ligands. Owing to the disturbance, there is an absence of the ganglion cells and the nerve plexus. As a result of which, there is a contraction in one region and distension in the others owing to the pressure. The same thing is shown over here, and this is how we get what is called as a entry ganglia. You will be wondering what is entry ganglia. It is nothing but the migration of the cells. Epithelial to membrane transition is important for this. EMT. The classification of the Hirschsprung's disease. So, according to the length, it can be a short segment, or it can be a long segment, or it can be total colonic agangliosis. So, this is what you people should remember. The mucosa and then the muscularis mucosa is a very thin layer over here. Then you have got the circular muscle, longitudinal muscle. It is here where we are supposed to look for the ganglion cells. In this region, it will be immature and not very effective. Thanks to Bennett McGraw-Hill for this diagram. The classification of the allied disorders of the Hirschsprung's disease. It can be because of the immaturity of the ganglia, hypoganglionosis, or neuronal dysplasia. And there can be other diseases also, such as megacystitis, segmental dilatation, internal anal sphincter achalasia, and chronic idiopathic pseudo-obstruction. So this list of differential diagnoses also you can have in mind. This is a particular picture that is quite interesting. So this is a functional obstruction. Look at this beautiful word, functional obstruction. It is not a mechanical obstruction. And as a result of this, there is no peristalsis. There is a distension of the segment. And in this region of stasis, there is dysbiosis. Abnormal microbes develop. Bowel distension continues, and there can be a decreased blood flow. Tissue injury also can be there. So this is what is happening thanks to nature reviews for this particular picture as such. And this diagram again from cellular and molecular gastroenterology and hepatology. It explains it. A healthy gut is over here, and in this region, there is a mucin retention, crypt dilatation is seen. And further on, I find that there can be inflammation, loss of the epithelial integrity, bacterial infection, and sepsis. Quite easy for us to write once you have the diagrams. The classification, this again, I would like you people to kindly memorize. So classical segment or a short segment. It can be a long segment Hirschsprung's disease, total colonic aganglionosis, and total intestinal aganglionosis. There is an extreme where not only the large intestine, but it goes up to the jejunum. Ultra short Hirschsprung's disease is defined as aganglionosis, and there is about 3 to 4 centimeters of the intestine which is being involved. So this is the normal anatomy of it. I would like you people to kindly go through what are the various parts. The upper part of the rectum is over here, and then there's the lower part. There is the anal canal. There is something called the white line, and then there is a transition zone. Here I find something like tooth, and this is called as a dentate line. It is particularly above this that the biopsy must be taken. So ultra short segment, what is it? You find it is above 3 centimeters in line, and it is above the pectinate line. The pectinate line is somewhat shown over here. So the anal verge is there, the transitional, the dentate line is over here. And there can be the various studies that can be done to identify the achalasia. Sometimes we see only nerve bundles and blood vessels, but ganglion cells will be absent. There are two theories. One is the neural crest cells will not be able to reach the distal layer. The second theory is the ganglion cells do reach, but they fail to survive. And these are the things which are abnormal in a case of Hirschsprung's disease. This molecular basis you people will have to write. Kindly by heart. This is again the same of the other picture that I had said. This is an animal experiment in which they had demonstrated it. They have created an area of aganglionosis, as a result of which there is a dysbiosis, abnormal microbiological growth. And there can be the various other things such as the inflammation and perforation which can come in. And ultimately you find that there are the nerve cells without the ganglion cells. Now it is beautifully explained in this diagram. There is an intestinal peristalsis and there is a downward movement. Now, in a case of fully colonized ENS, you find that it is healthy. Enteric nervous system or cells. But when it becomes abnormal in the transition zone, you develop a Hirschsprung's disease. And this can be because of RA.T., ED and RB, probably endoplasmic reticulum, that is over here, SOX10, FOX2B, and ZFX1B. These are the things which will be abnormal. Kindly by heart this particular diagram. What are the methods of surgery? In this one, anyway, surgical treatment is mandatory. You'll have to remove the aganglionic segment and re-anastomose. There are three methods over here. In this one, I'll start from, you find that part of the aganglionic segment, the yellow is the aganglionic, it is retained, whereas the ganglionic segment is connected to it. Therefore, this amount of pressure is sufficient to overcome the sphincter. Whereas in these two, there is a slight variation. In one, there is a complete removal of the aganglionic segment, whereas in another, there is a partial removal. Swenson and Sove. So I would like you people to kindly go through these things. So this is the ganglionic region and this is the aganglionic region. Over here. See what is happening. You find that the ganglionic region, there is a constriction, but then in the hypoganglionic region, there is a contraction and then there is a distension. A total coordination between the histologist and interprofessional team is mandatory. The treatment I had already mentioned, there is a pull-through surgery that is shown. Frozen sections are having their own limitations. An intraoperative biopsy should be taken at least at 2 different sites. Other than that, there can be immunophenotyping. After the resection, there can be the treatment, and these are the various things that have been mentioned. Frozen section, surgical, longitudinal, etc. The pitfalls in this is you find that the extent of innervation cannot be assessed. The longitudinal samples are not properly being marked, and the surgical resected specimen will be a little different from the frozen sections. The differential diagnosis will be meconium ileus and meconium plug syndrome. These are two different things. Probably this comes under the cystic fibrosis. And the other differentials, strangely, you find that diseases that are totally unconnected with the intestine are there. This is the DiGeorge syndrome, where there is a velocardiofacial. The main thing here is a cleft palate. And congenital heart disease can be the genitourinary and craniofacial. Whenever there is an abnormality in one side, kindly look for abnormalities elsewhere. That's a dictum. So, what we have seen until now is the subheadings. These should lead you to the answer. I hope you are able to identify this person. And incidentally, this is a painting of the Hirschsprung College, Copenhagen. Thank you for your patience.